Welcome all of you. Good evening and good morning to our international faculty. This is on behalf of the Urological Society of India. I extend a warm welcome to this andrology webinar on common problems in andrology. And today we have international faculty and eminent national faculty participating in this webinar. On behalf of the Urological Society of India, I extend a warm welcome to all of you. But let me make a sad announcement that today we lost one of our senior members from South Zone, Dr. V. Ravindranath, who was a very tall figure in the Urological Society of India. He was the past president of the Association of Southern Urologists. So I would request all of you to observe a 15-second silence in tribute to his demise today. We start from now. Thank you. So let me welcome our international faculty, Dr. David Ralph, Dr. Sijo Parketel, Dr. Stephanie Butler, and our own national faculty, Dr. K. Hanmantaya, Dr. Prakash Kotari, Dr. P.C. Malhotra, and the Andrology Subspecialty members, Dr. Hota, Dr. Shivam Priyadarshi, Dr. Vinod KV, Dr. Raman Tanwar, and Dr. Pramod K. So let me now ask our President USI to make his opening remarks, and then we move on to Dr. Rajiv Sood. Over to you, Dr. Mallikarjun.
Thank you, Keshav. Thank you. But heartfelt condolences to the family of Dr. Professor Ravindranath. They're really a tall figure in the Southern Urology circles, no doubt about it. Well, coming to the point of today's webinar, it appears to be one of the most interesting things in the recent past we had, which will be encompassing the whole gamut of andrological problems which we commonly see but rarely discuss in the conferences and all. And it's glad to see the who's and who of the sexual medicine who are there. Dr. Prakash Kotari, Hanmantaya, and Dr. Ralph and Dr. Sijo are all there, and our eminent international faculty is there. I think we enjoyed this session tremendously. At least I need to learn something more, because which mostly are not discussed in our routine neurological conferences. Thank you for selecting this beautiful topic with a fantastic faculty, Dr. Hota, and great beginning by you and in doing this andrology webinar. Thank you very much, and all the best to this webinar.
Thank you, Dr. Mallikarjun. Now I invite Dr. Rajiv Sood, Chairman, Indian School of Urology, for his opening remarks.
Thank you, Keshav. President USI, Dr. Mallikarjun, our eminent faculty, national and international, today is the special day. Today is the day when we are celebrating the International Men's Health Month. We had many programs in this month already organized, and we have amongst us one Dr. Prakash Kotari also, who is Padma Shri, highest awardee of civilian award holder, one of the civilian award holder in sexual medicine. That is our honor. So many stalwarts are there related to this subspecialty. I recount my days when I took over as the deputy convener on behalf of USI of subspecialty of andrology for 2 years, and then I was convener, and thereafter we had this subspecialty growing, and I'm very happy today to share that those who are leading this subspecialty, including Dr. Hota, Dr. Raman, and all others, Dr. Vinod, and all others who are there, Shivam also from our zone, North zone. So all are doing wonders. We had a very humble beginning, and then we had many meetings. And not only now, for last almost 10 years, we are pursuing this subspecialty under Urological Society of India. And today is really a day to remember. I bring again greetings on the occasion of Men's Health Month where we are celebrating all over India. We are trying, this has been adopted, this subspecialty in two national subcommittees by Indian Medical Association. That is the largest association of around 35 million doctors in India. And that is the IMA Standing Committee on Sexual Medicine, as well as IMA Standing Committee on Men's Health. So these two important developments, and after that adoption for creating a curriculum, dedicated curriculum for both the subheads. That is, one is sexual medicine, that is starting, and also the men's health. So these are great efforts and grave achievements, and everywhere, right from the beginning, Urological Society has been in the core of all activity. So Urological Society of India is to be congratulated. Today, I wish all the best for this discussion, which is going to be our treasure in the archives of Urological Society of India. And let us begin these deliberations today. Wish all of us a good luck. Back to Dr. Keshav.
Thank you, Professor Sood. Now I would invite Dr. Hota. The stage is yours, Dr. Hota.
Thank you, sir. Mr. President, Chairman of the ISU, Deputy Chairman of the ISU, Honorary Secretary, our esteemed faculty from outside the country and faculty from the country. It is good morning to the transatlantic faculties, good afternoon to our faculty from UK, and good evening to all. Now, thanks at the beginning, because the andrological subcell or the cell that has been formed, we have been trying to do our best to provide a good academic program. In between, also we have done one very good program recently, the OSCE program. Now this is the second after that. Now I would also appreciate that we are very thankful to the Urological Society of India for having reposed confidence in us to organize such programs. Now with this few words, I welcome you all to this program, and we start our talk with Professor Hanumantaya. Slide. Now, as you know, Professor Hanumantaya is the professor of dermatology, and he is in Karnataka in the medical college, Kolar, the SDU Medical College. He has got a 27 years experience, and he has already made 30 publications. He was trained in leprosy at CLTRI Chengalpettu and HIV and AIDS training at Government Hospital, Tambaram. He's a man who is wealth of knowledge, with real good and huge humility. With these few words, I request Professor Hanumantaya, kindly start your talk, sir.
Respectful regards to Professor Emeritus of Medicine Dr. P.S. Shankar and late Dr. S.G. Nagalatimat, the pathology professor. Both of them, they taught me, one who dares to teach will never cease to learn. Dermatology is a visual discipline. Familiarity with the clinical presentations by repeated viewing of patients and correlation with known disease entity mentioned in literature can make this specialty an interesting one. As they say, the eyes do not see. The eyes do not see what the mind does not know. And hence, a sincere attempt must be made to learn the patterns of skin manifestations. Dermatology is the branch of general medicine which deals with the disease of the skin and cutaneous manifestation of the internal organs. It also deals with the venereology and leprosy. In 1918, European League announced the term venereal disease with only 5 diseases. 1974, World Health Organization recognized that they are the simplest of simple communicable diseases communicated during act of sex. Hence, the They stressed the mechanism of the disease. They designated the term sexually transmitted disease. In 1997, the entire America was under the grip of fear of HIV. Anything on the genitalia, they started equating with the HIV/AIDS. So because of that, World Health Organization redesignated the term sexually transmitted disease to reproductive tract diseases or reproductive tract infection. Here we see the anatomical region. Friends, what are the diseases we encounter on the penis? Commonest are candidal belnoposthitis, herpes genitalis, bacterial ulcers, urethral discharge, venereal warts, molluscum contagiosum, tinea cruris, scabies, benign pearly papules of penis, and steatocystoma multiplex. Candidal belnoposthitis, yes. Belnoposthitis describes the inflammation of the glans penis, and posthitis means inflammation of the prepuce. In practice, both areas are often affected together, and the term belnoposthitis is then used. What are the causes? Commonest cause, Candida albicans. Predisposing factors, diabetes and poor hygiene. Friends, there are 4 photographs. Here, carefully, if we see, a person is trying to retract the prepuce. He is trying to retract the prepuce. He is not able to retract the prepuce. Entire prepuce is edematous, and studded with the curdy, creamy, moist scaling. With a great difficulty, after everything is cleaned, and then he retracted with a great pain, then we see linear fissures. Here, before cleaning, so just when he retracted, the entire glans penis was studded with the creamy, moist, curdy scales. Partially treated, you see a linear fissures. So this is a typical of candidal belnoposthitis. In textbooks, they say 150 milligram of fluconazole is more than enough. But honestly, I tell you, friends, the recurrence is more common. Instead of fluconazole single dose, you give fluconazole 150 milligram alternate day, minimum for 4 to 6 tablets. Herpes genitalis, yes. Today, herpes genitalis is much more common, caused by both type 1 and type 2 viruses, but type 2 is much more common. The incubation period is usually 4 to 7 days. When we see, initially we see on the area where the herpes genitalis virus is entering a macule, slowly it becomes edematous. In 2 to 4 days, we see vesicles. The vesicles are thin roofed. Within 24 hours, they rupture, and then they give either erosions or ulcerations. Usually, for the first time, when it occurs, we call it as a primary herpes genitalis. When it occurs second time, third time, we call it as a recurrent herpes genitalis. So, patients may complain of burning sensation, lymphadenopathy, fever, all those things in first attempt. Second attempt, comparatively, symptoms are less. The treatment either acyclovir or valacyclovir. Both acyclovir and valacyclovir, one and the same drug, but in the valacyclovir, valin is tagged, so the bioavailability is much better. Or we can give famciclovir. Bacterial infections, commonest bacterial infection, trypanosoma, that is the syphilis, Haemophilus ducreyi, soft chancre, Klebsiella granulomatis, granuloma venereum, and Chlamydia trachomatis, that is the lymphogranuloma venereum. Here, first photo, 100% clean ulcer. Clean ulcer indicates there are no neutrophils. Borders well defined. So, indurated, comparatively painless, single, indurated, clean ulcer. This is the trypanosoma or primary chancre. This is a superficial, shallow, painful ulcers. Along the anatomical lines, it is expanding. Multiple ulcers also may be seen. The surface is covered by white necrotic tissue. Here, this is a soft chancre caused by Haemophilus ducreyi. This is a tumor of granulation tissue. Just a touch, it starts bleeding, friable tissue. So typical of granuloma venereum. Earlier it was called Calimnematobacterium granulomatis, but today we call it a Klebsiella granulomatis. And here the ulcer may be so minimal, we may not see, but on either side we see cork balls. There is a enlarged, painful lymph nodes, lymphogranuloma venereum. At the end of my 28 years service, I am honest, only 50 to 60% clinical diagnosis of mine in my OPD is correct. Rest of the time, either because of the partial treatment or mixed infection or background of the HIV, clinical picture is changing. So instead of making individual diagnosis, we can just make it as a bacterial ulcers. We can start syndromic management. If we are sure it is a primary syphilis, injection benzathine 24 lakhs intramuscular after test dose. My professor all the time used to tell, a night with the Venus, a night with the Venus, rest of the period, rest of the day with the Mercury. Today, that slogan has been changed. Simple one injection benzathine penicillin, 24 lakhs, 12 lakhs on either buttocks after test dose. Plus, compulsorily we have to give doxycycline or azithromycin for 15 days. It will take care of all the bacterial infection of the genitalia. Urethral discharge, yes, 80% of the time it is gonococcal, but definitely 20% of the time it may be Candida, Chlamydia, Trichomonas vaginalis. Patient usually complain of increased mucus secretion, discomfort while passing urine. After 2 days, he starts complaining of purulent discharge from urethra. If we take the smear, yes, immediately we see intracytoplasmic gram-negative diplococci. The treatment either azithromycin and cefixime plus doxycycline 100 milligram 1 BD for 7 days. If we give azithromycin or cefixime, still we have to give doxycycline 100 milligram 1 tablet 2 times a day for 7 days. Friends, condyloma acuminata. See, all around the corona, fleshy, exuberant, reddish, verrucous lesion. So almost all around the corona sulcus, it is present. Here, it is a papillar form. So for this photophyllotoxin, just if we apply, it melts like a butter in the sun rays. So when you are applying, first and foremost, educate the patient that this particular medicine is not having the eyes, not having the brain. Wherever it comes in contact, it destroys. So that's why cover all the other parts with simple Vaseline or liquid paraffin. Then personally you apply this particular medicine. After 2 or 3 hours, let him wash. If we apply regularly, it is extremely good. Within 2 or 3 sittings, entire these lesions will melt like a butter. Today, laser therapy, cryosurgery, electrofulguration are all present, but in my so many years of service, I see photophylline is the most ideal drug. Molluscum contagiosum. 1978, I joined my diploma in dermatology. My teacher told me it is a lovely pearl, a gift from girlfriend. But in 1990, when I joined for my MD, my professor told me it is a deadly gift from girlfriend. I asked, what is the difference? In 1978, there was no HIV background. Molluscum contagiosum will never come alone. It comes with the many diseases. Among many, HIV is the commonest. They look like a pearls, almost a pearly lesion with central umbilication. The best treatment is physical scooping. Sometimes we can use photophylum or imiquimod, lasers, cryosurgery, or electrofulguration. Friends, Tinea cruris. Tinea cruris is also present, and it is on either side of the crural region and also as well as in the mons. So convex border, advancing inflammatory borders are almost towards the ground. The treatment is emrolfin topical and tablet itraconazole 100 to 200 milligram, one tablet 2 times a day for 2 to 4 weeks. Scabies, yes, even today scabies is common. When patient complains of itchy lesions over the genitalia, first think of scabies. The best treatment is personalizing permethrin below the neck and ivermectin 12 milligram tablet. Benign pearly papules of the penis, 100% normal. In fact, they increase the lubrication during sexual act. In cats, they increase the sexual pleasure. So sometimes if patients insist that it should be treated, then only it should be treated. Otherwise, it is 100% normal. Steatocystoma multiplex. Steatocystoma multiplex is nothing but a simple epidermal sebaceous cyst. If left, nothing will happen. If they go on increasing the size, sometimes calcium deposition, sometimes ulceration may take place. So such lesions can be easily excised. Friends, any case, any genital lesion, compulsorily ask for blood sugar, blood VDRL and HIV 1 and 2. For every patient, we should counsel partner notification, maybe partner 1 or multiple partners, and compulsory treatment for everyone, condom promotion, treatment accordingly, and regular follow-up. Thank you very much for giving me time to complete my slides within time. Thank you, sir.
Thank you. Thank you so much, Professor Hanamantaya, for your so lucid talk on management of common cutaneous lesions of the penis. In fact, it was quite illustrative with clinical photograph. And we are thankful because you have finished before time, sir. Now we'll go to the next speaker with one request that all speakers to kindly stick to the time, because the allotted time is 2 hours. A lot of discussions and deliberations are to happen at the end of the first session. Now I call upon Dr. Stephanie Butler. Dr. Stephanie Butler. She is a licensed psychologist and a certified sex therapist and supervisor. She is the director of the Butler Institute and creator of LearnSexTherapy.com. Dr. Butler is the author of best-selling textbook, What Every Mental Health Professional Need to Know About Sex. Third edition is in press. And counseling couples before, during, and after pregnancy, sex and relationship issues. An in-demand speaker, she is frequently quoted in the media, most recently in the Atlantic, Men's Health, and Business Insider. In fact, we are going to hear from her about the tips and tricks of couple therapy. Madam, the stage is yours. You are welcome, and the stage is yours.
Good morning from California. It is coming up on 7 a.m. here. Thank you for having me. So I'm going to share with you, I have been a sex therapist and a psychologist for 20 years, and lots and lots and lots of experience with couples. When I was asked to, and of course I was very honored to be asked, when I was asked to give this presentation, I thought, what can I share with you that would be practical, that you can really take things away? So I think solution-focused sexuality counseling will be helpful to everyone. And you may not take everything from this talk, but even if you take away a couple of ideas, it can really be helpful in helping your couples resolve things quickly. So with solution-focused therapy, which is created by Bill O'Hanlon and Stephen Miller, 2 psychotherapists here in the United States, the idea is to stay focused on the possibilities. And of course, when people come into the office, they, often they have complaints that have been longstanding, that they've had for a long time, and they're miserable, and they really want to talk about the problem, and sometimes talk and talk and talk about the problem, but really they're in your office hopefully for some solutions. So I try to with many couples, of course, if things are very serious, people come in, they've been sexually abused or terrible things have happened to them, then I know I'm going to do longer therapy with them. But for many people, the solution focus works. So I just say things like, I don't even use the word problem. I say, if you could tell me what's going on in just one sentence, how would you like things to improve? And I think, with physicians, I know time is always very valuable, but to ask, what can I help you accomplish in the time that we have? And also asking, how will you know when you have met your goal? So get them focused right away on what it is, what the solutions are. When teaching about solution-focused therapy, I'd like to talk about the acronym GEMS. So G for goal setting, E for exceptions, M for the miracle question, and S for scaling. Let me describe what I mean. So when people come in, they have all kinds of goals. They, for men, and I worked next door to a very busy urology practice for many years. So I've worked with many, countless men and their partners. So, they come in and they say things like, oh, we want to have sex like we did when we were young, or I want to be able to last forever and ever. Whatever it is that they say, sometimes you have to talk to them about getting their goals to be reasonable and attainable and measurable. And so an unreasonable goal would be, we want to have sex like we used to have. A reasonable goal is having regular pleasurable sex. An unattainable goal, I want to last long enough for my partner to always have an orgasm. Well, maybe you can, but maybe that's not so realistic. So how about a goal like lasting long enough to have some fun and enjoy ourselves without having any pressure? And when you're working on the goals, you want to facilitate agreement between the couple. You want to use inclusive language with them. So saying things like, what do the two of you want for yourselves? How do the two of you want to behave when you're being sexual with one another? How can I help both of you? How can the two of you solve this problem together? So in other words, getting them to join together and have that feeling that they are working together as a team. If they start to look at one another and they start to quarrel or fight or kind of snipe at each other, just ignore it. Don't even pay attention to it, because when you pay attention to it, you're rewarding them. You're kind of feeding the problem talk. Stay on your message. Well, let's bring it back to what is it that you're going to do to resolve this problem. Reframe the conflict. If they're having conflict, you say, oh, well, I can see that you're very passionate people. Don't say anything about, oh, stop fighting, or, it's not worth fighting about, or, you kind of sound like a parent when you do that. You don't want to do that. You just say, oh, you're a very passionate couple. That's wonderful. You really care about this problem. Focus on their strengths. Oh, you're two very intelligent people. I'm sure that you can figure out a way to solve the problem that you're having. Or, oh, you seem like you're creative. I'm sure you can come up with some solutions for the problem. From GEMS, also exceptions. So you want to talk to the couple about times when things went well. So everybody gets, when they're upset, they get focused on how awful everything is. We call it in English here, we call it awfulizing. So they awfulize about what's happening. And you just don't pay attention to it too much and just say, well, was there ever a time when things went well? Oh, the couple may say, oh, well, we had great sex one morning last week. And then you can ask them, well, what was going on to make that different from you? And they can, maybe they tell you, well, because it was the morning, we were more relaxed and rested, and I think things went better. And then you can ask them, so how can you recreate those times when things went well? Well, let's see, we could agree that we could have sex in the morning more often. Okay, that sounds good. Or we can try relaxing more before we have sex. Sounds good. The miracle question. Every therapist here in the States uses the miracle question at some point, no matter how they work or how long they're working, because you want to get people focused on the possibilities in the future, the good things to look forward to. So you can ask them, if you were to wake up in the morning and the problem was solved, what would be happening? That's the miracle. If you were to wake up and the miracle had happened and everything was better, what would be going on? And have them describe to you what would be happening. Oh, we'd be having regular sex. It would be pleasurable. Okay, great. That's wonderful. And then say, okay, so sounds like you have a lot of hope for the future and you know what you want for yourself. So let's start talking about some solutions. The last thing are scaling questions. And scaling questions, everybody has used scaling questions, but use them with your patients. Say things like, on a scale of 1 to 10, how much improvement do you need to recognize that things are better? So in other words, you're not going to go from a 3 to a 10 right away. Usually we make progress in incremental steps. We want to just not draw attention to the fact that progress may go more slowly, but to say, let's create a path for getting to the solution, to getting things resolved for you. So you say, on a scale of 1 to 10, how much improvement do you need to recognize that things are better? So get people focused on what is good, what is working. And then another way of asking this, where are you today on a scale from 1 to 10? And say the person says, well, my erections, the quality is like a 3. Okay, it's a 3. So what do we need to do to get you to a 5? Do you think you can get to a 5? And how would that be? Maybe if you used your medication correctly. So let's go over again how to use whatever it is, Viagra, Cialis, to get a better result. Maybe you don't want to use numbers. Some people are kind of averse to numbers, or you want to be like a little softer in your approach. You can just use a metaphor. So you can say, well, in terms of your desire, you feel like you're at the bottom of the staircase. You're too tired all the time. And, it feels like a lot of effort to be sexual with your partner. So what would need to happen for you to just take one step up that staircase? Well, maybe I could do some things to relieve stress. That might go along. Okay, great. What are you going to do to relieve stress? Get very behavioral with them. Here are some more solution-focused techniques. So we're leaving the land of gems and we're going to other techniques. Normalize. Now, I talked about awfulizing. This is normalizing. Just everybody, I've got to tell you, I scheduled my own appointments. I would take the phone calls myself, and men would actually say they would have premature ejaculation or delayed ejaculation or erectile dysfunction. And they would say to me on the phone, like they would tell me about their problem. And they would say, have you ever heard of this before? Has anybody ever come in and asked for help with this? I'm like, oh my God. Like how many people today have called me with this problem? So I think normalizing and saying, this happens. It's normal. It's normal. Every man has ED at some point in their life. And if they start to say, no, well, only me, you say, no, it's very common. It's normal. Things will improve. Or saying like, difficulties with erections when you're stressed, that's pretty normal. That's your body's way of saying you need to rest and relax, something like that. You also want to validate the couple's feelings. I worked with someone, and if I said to her, I feel upset about something, she would say, oh, don't be upset. Or I feel, sad. Oh, don't be sad. I didn't like that. I was like, you know what? I feel the way I feel. And I think people really like it if you can validate their feelings. So, to say, oh, you know what? Yes, it is frustrating to struggle with PE. Learning how to develop control can be pleasurable and fun for both of you. You'll be less frustrated. So, validate the feeling. I understand feeling sad about your sperm count. I get it. It's normal to feel sad about it. Let's see what we can do to improve things for you so that you can hopefully get pregnant naturally. And then another thing, something like the miracle question, Bill O'Hanlon said, get people to do one thing differently. If you do one thing differently, it creates a domino effect sometimes. So just change something, just do something. Okay. So you can change the action, how people act. So I might say, well, how would you act? Like if a man has delayed ejaculation, how would you act if this problem was solved? Meaning, could you act like you're having an orgasm? Can you act like you're ejaculating? Can you act like you're really enjoying having sex? Can you act like you're relaxed enough to ejaculate? Just act it out. Ask something like, what did you used to do when you acted like you had sexual desire? Well, let's see, I would think about having sex. Okay, so why don't you start thinking about having sex? That would be a good thing to do. You could think about it on your travels to work. You could think about it when you're taking a shower. You could think, so this kind of thing. How did you act when you had a good erection? You told me that you had a good erection last weekend. So how are you acting? Oh, I think I was acting like very confident, like I didn't have anything to worry about. Okay, keep doing that. Act confidently when you're in the bedroom. Change the pattern of behavior. Do one thing differently. Tell the couple if they're bored or whatever, have intercourse at a different time of day, or they're always tired, or they're whatever is going on. Have intercourse at a different time of day, have intercourse in a different position, have intercourse in a different room, right? You could suggest something simple. Oh, how about, you could change the order in which you undress each other. So the person who usually gets undressed first, maybe they can undress the other partner first. Take a shower before you have sex. Let your wife have her orgasm first, then you can have your orgasm. So you're just changing the pattern. Here's some final do's and don'ts. So as you're counseling the couple, don't allow them to return back to talking about the problem. If they start talking about the problem, if they start talking about the problem and you start paying attention to it, all of a sudden you're back in all that junk and you don't want to be there. You want to stay focused on the future and on the solution. So, deflect, say, oh yes, I know I heard you say that this was frustrating for you. I get it. And so the steps that you're going to take to get from 5 to 6 this week, what do you remind me or tell me what it is that you're going to do? Don't give too much sympathy about the problem. Don't get into awfulizing and problem-focused language. You're just going to, it's like fanning the flames and getting them so worried. Focus on the future and the possibilities. At the same time, don't give false hope about the problem. Don't tell the couple, oh yes, I can help you have sex like you did when you were in your early 20s. Of course, there are all kinds of things that don't say that. Bodies change, people change, genitals change, function changes, but being able to say, whatever is going on, things can be fun and pleasurable for you. Let's focus on what still is working and see how you can do that more frequently. And finally, some do's. Be collaborative in problem solving. Now, I happen to know, and I was talking earlier that I am in Orange County, California, where it is 7 a.m. And we have actually a very large Indian population in this area in Southern California. And I know the culture likes to have an expert who tells the people what to do. And that's okay, that you can do that. But I think it can be very helpful if you get the couple collaborating with you so that they become part of the solution and they get creative. Sometimes if you ask them to brainstorm and come up with ideas, sometimes couples surprise me. They know themselves best and they know how their lives go. So work with them, draw out their solution skills, let's say. Maintain an optimistic outlook. You hear how I'm talking about things, you know, stay light, stay optimistic, stay positive, and at the same time, be empathic, be attuned to what is going on so that they don't feel dismissed and that you're just putting a Band-Aid on a problem. Praise even the tiniest progress, whatever happened that was good. You say, oh, that's wonderful. We say in California, that's awesome. That's awesome that happened. And provide encouragement when change is slow. So sometimes things are going more slowly, you know, say with prostate cancer and healing after prostate cancer. Sometimes it takes months, and just say, you know, yes, the body takes time to heal. And you just need to be patient, and I'll be patient along with you and give you support. So that is solution-focused therapy, and lots of tips and tricks for you to take away. And I thank you very much for having me join you today at this wonderful meeting.
Thank you, Dr. Stephanie, for this beautiful talk delivered just now. You know, you have given us a lot of impetus and how to go for a focus-based sex counseling and sex therapy. In fact, thanks a lot from the Urological Society of India for giving such a nice lecture. Now, thank you, madam, again. Now we go to the next topic, which is again very interesting. Prakash Kotari doesn't require, Dr. Prakash Kotari doesn't require any introductions. He is known not only to India, he is known to all parts of the world as a sexologist of reckoning, of reputation, and he is one of the most, popular persons among physicians, surgeons, gynecologists, all alike. Now he is Padma Shri awardee. As you know, it has been mentioned that it is one of the highest awards, civilian awards of the government of Odisha, India. Now he is a founder professor of sexual medicine, St. G.S. Medical College and KM Hospital, Mumbai. He was the president in the 7th World Congress of Sexology and first International Congress on Orgasm. Original research work on orgasm and Kama Sutra, for which he was awarded the doctorate degree, awarded the title of Sexologist of Asia by Asian Federation of Sexology. He received gold medal by the World Association of Sexology, WASH. As you all know, he has got the highest civilian award of our country. Now, to tell you a little more about him, since our youth days, when we are in our initial part of our medical profession, at that time we had heard him. You know, he's the first man in the country to have deliberated on sex and the importance of taking care of sex. Now, the other thing which I am reminded time and again, that he is a person who brought the principle that sex should not be confined to bedroom. He brought sex from the bedroom to the drawing room. Welcome, sir. The stage is yours.
Sir, please unmute yourself. Dr. Prakash Kotari, please unmute yourself. You are still muted. Yes, perfect.
Fine, thank you. It is indeed a pleasure for me to be among you this evening. And I thank you, Dr. Hota, for your remarks about me, and you, ladies and gentlemen, for endorsing them. The topic on which I intend to focus my professional attention is sexual myths. You see, myths are fantasies shared by the whole culture, and they exist because it has a common mass appeal. You see, any case which you see, whether the problem is psychological or organic, there's one thing in common, that there's tremendous anxiety over a sexual situation, which is brought about by the negative feelings, which gets into conflict with the experience of failure. The failure recurs, anxiety increases, and a vicious cycle is set up in which hostility, shame, guilt, fear become the part of the pattern for any potency problem. But unlike West, this particular anxiety in our country is born out of myths and misconceptions. In our history taking, normally we ask simple 4 questions. And this we have developed at KEM Hospital. And the model has been tried in more than 50,000 patients. And you can diagnose a case as if you are diagnosing a digestive problem or a respiratory case problem. We have 4 questions to the male and 4 to the female. Male, desire, erection, penetration, and orgasm. Female, desire, lubrication, penetration, and orgasm. You'll be able to pinpoint the diagnosis. Ejaculation in man and vaginal contraction in female are the dispensable pelvic physiological concomitants. Having said this, at the end, I invariably ask one question. That what do you attribute your problem to? And believe me, 8 out of 10 people will say, Doc, it's because of the previous habit of masturbation, or I have excessively dissipated the semen, or penis size, or my partner has reached, whether reaching climax or not, I don't know. Let's tackle the first myth, masturbation. After completing my postgraduate workshops at St. Louis, Missouri with Masters and Johnson, and I started my department at KEM Hospital, where there used to be more than 100 people, and I would give a talk to these patients to try to clear the guilt. For masturbation, I would say that, look, there is no other activity which has been so roundly condemned, so frequently discussed, and yet so universally practiced than masturbation. Masturbation is beneficial and not harmful. It's one way by which one can avoid sexually transmitted diseases and unwanted pregnancies. And my opinion, if masturbation were to be suppressed, the cases of crimes against morality would enormously increase. There used to be a great round of applause. But KEM was a free hospital. So all these patients after 3 or 4 terms will come and tell me, Doc, you have given a nice talk, but the guilt still remains. At that time, I realized that just telling masturbation is normal is not enough. They need to be convinced that masturbation is normal. Then I changed my entire modus operandi. I would ask them, does intercourse lead to any problem? No, doctor. Masturbation? Yes, doctor. I said, look, gentlemen, during intercourse, what the penis does in a woman's vagina, it does the same in the folded palm during masturbation. Meaning thereby, if you know Hindi well, you can pick up Marathi faster. Or if you know English well, you can pick up French faster because of the same script. But what about excess, doctor? There's nothing like excess in masturbation resulting in weakening of the penis. The tongue does not become weak in a talkative person. Neither does it become strong if one observes silence. But doctor, tongue or penis mein to kuch fark hai. Look, gentlemen, tongue is highly vascular. Penis is highly vascular. Tongue does not have bone. Penis does not have bone. Tongue is centrally situated. Penis is centrally situated. Usually, when I explain to this, I must have seen about more than 50,000 patients. I have yet to come across a recurrence. Another misconception which you must be, it's all over the world. That is penile length. You see, penile length and width have been the yardstick by which man has measured his manhood and had his manhood assessed by his friends and wives. You see, what is the minimum length of penis for female sexual gratification? My logic is sexual length of vagina is 6 inches. I mean 4 inches of the vagina and 2 inches of the incompressible tissue in the front face of sacrum. So that makes it 6 inches. Only outer 1/3 has sensations. Inner 2/3 is virtually insensitive. This leads us to two logical conclusions that if you want to arouse your partner, concentrate only on outer 1/3 of vagina. Don't waste time inside because this is the era of time management. And second, what should be the size of penis for adequate sexual gratification? Anything from 2 inches or more is good enough. Longer the better is a Godzilla logic. I was writing a column in Femina and several other newspapers. I received one question. Sir, I have 4 inches penis. I am a rich diamond merchant and I want to increase the size of my penis instantly. I explained to him that anything from 2 inches or more is good enough. He just won't listen. The editor asked me that, Dr. Kotari, you need to reply properly. I have 4 inches of penis. I am a rich diamond merchant. I want to increase my penis size instantly. I replied that, look, the only way by which you can increase the size of penis instantly is use the magnifying glass. Not only that, after that, I made a little caution that don't use it in direct sunlight. Third one, the myth is very common, is about the myth about semen. You see, semen is vital, and that's why it should be conserved, is a misconception. 1 drop of semen equals to 100 drops of blood, and 1 drop of blood equal to so much of food is the most blatant misconception which I have come across. Conservation of semen is essential for a robust health and athletic excellence is another misconception. You see, sleep emission is considered as a very big disease, very grave disease. We need to explain to them that semen is manufactured 24/7 by the genital apparatus. If you don't remove it, it will go out by itself. If there's a glass, I give you a simple example, that if there is a glass full of water, and if I add more water to it, what happens? He says, doctor, it overflows. Similarly, if you don't indulge in intercourse, or if you don't indulge in masturbation, ultimately it will come out as sleep emission. Sleep emission is normal, physiological, and not pathological. You don't need to consult a doctor for this. You see, I found examples carry much more weight than just words. This is about the East. Even the Western world carries the myths about semen. All over the globe, if a man reaches orgasm early, what do they call? Premature ejaculation. The moment you say premature ejaculation, you are propagating a myth that ejaculation and orgasm are synonymous. In fact, it is proved neurophysiologically that both are different and one could occur without the other. And we all know that orgasm lies between the 2 ears and ejaculation lies between the 2 legs. Now, you all are urologists. I'll ask a simple question. Suppose if a man is reaching orgasm early and he is not, there is no formation of semen, which could happen in prepubertal boys, in elderly individuals with low testosterone, or those who are on tamsulosin or carbamazepine. If that person reaches orgasm early, what will you call? Premature ejaculation with an ejaculation. But that's a paradox. Early orgasm is a better, simple terminology. Similarly, when a person takes a very long time, delay in reaching orgasm, you know, what do they call? They call it retarded ejaculation. Just imagine, look at the English language. Can ejaculation ever be retarded? It's a retarded thought. You see, this is a global misconception. And to remove this misconception from the world, I convened the first ever international conference on orgasm, where I cleared that orgasm is between the 2 ears and not between the 2 legs. There are four varieties of dysfunction. Either you reach orgasm early orgasm. You reach with a delay, delayed orgasm. You reach orgasm, but there is less pleasure. It's an impaired orgasm. There is no pleasure at all. It's an absent orgasm. And this is the only classification which has male and female parallelism. I tried to remove this misconception even from the Western world, but I must honestly admit that I failed, because this misconception is so deep-rooted that even today, the urologists will talk in the same manner. Even the DSM-5, the Bible of psychiatry, carries the same misconception. I think it's high time now which we need to stop. I know Dr. Hota will tell me, Dr. Kotari, you are talking only about the males. What about the females? Yes, there is a misconception which is very common, that most women understand and most men feel that lubrication means orgasm. No. What happens? I mean, how much time do we enjoy orgasm? Not more than half a minute per week and not more than half an hour per year, but still it's an important phenomenon. You see, the mathematics of misery and happiness chiefly depends upon this. What happens when a woman reaches orgasm? अगर गुजराती लड़के हैं तो मुझे पूछना पड़ता है, भाई तुमने संतोष મળ્યો? Punjabi they use the word samadhan. Tamil they use the word trupti. I mean, Telugu they use the word santrupti. The best word you find is in Malayalam. Once I had discussion with Osho, and I told him that the best word is in Malayalam. He said, "What is it, Dr. Kotari?" I said, "It is Rati Murcha." Rati means intercourse and Murcha means trance. Well, only one question we need to ask. Desire, lubrication, and when the sexual tension reaches the peak, a woman reaches orgasm or climax. She gets a feeling of enough and nothing more. You see, orgasm is like a sneeze. If a woman has had one, she knows about it. Otherwise, any attempt to explain it is like explaining a rainbow to a blind man. Other misconceptions are also there, like menopause is the end of sex life. No, it's the end of reproductive career. Another thing is, and not the sexual career. Another thing is, most people, one failure in making it means an end to sex life. I give them an example that, look, a man like Gavaskar scores 2 centuries in the first inning, gets bowled in 0 in the second inning. That doesn't mean in the next test he will not score a century. So emphasize the fact that failures are common, but failure does not mean an end. Well, sex after 60 is not possible. That view needs to be changed. And sexuality is as important for the older set as it is for the just set. Now, the last myth, which is the myth of myths, and the biggest myth, if you ask me, is this: that a sexologist is always a very highly qualified professional. Friends, remember, he could be a qualified quack wrapped up in medical degrees, or he could be an unscrupulous, unqualified individual. Well, friends, much has been omitted in this talk that might have been included, but it's fervently hoped that nothing has been included which ought to have been omitted. Thank you for inviting me. Obliged.
Thank you, sir, Dr. Kotari. Thank you for the so nice explanation. The way you have presented, it was very, very convincing. And really, we believe that you have finished very much in time, sir. And besides, as we have mentioned earlier, that you are the father of sexology in our country. We always look forward to your propositions on how to go for, the variety of sexual problems that comes in. Unfortunately, in the present scenario in our country, we do not have much of sexologists who can really deliver the good. We look forward to having much more disciple from you to solve this sexual myths and misconception and provide sex therapy. Thank you again, sir. Now we go to the next speaker. Our next guest speaker is no other than Dr. David Ralph, and he is joining from London. Dr. Ravi Ralph is a known figure in the field of andrology internationally. To tell you briefly about his bio, he is is a professor of urology and andrology at University College of London, University College of London Hospital, University College and Hospital, London. Now he is going to speak on update in the management of Peyronie's disease. Now, as regard, he has got good number of publications, and he is also held lot of vital positions in EAU and also in andrological, the European Society of Sexual Medicine. Now, I welcome Professor David Ralph to deliver his talk.
Thank you. Hopefully you can all hear me now, and I'm sharing my slide. I've been asked to give an update on the management of Peyronie's disease. So we'll go through medical treatment upgrades and mechanical and obviously surgery as well. See if I can move my slides, 1 second.
Full screen. Can you make it full screen, sir?
Sorry?
Full screen. Can you make it full screen?
This full screen. Hang on.
Yeah. I think it has, the setting has gone back.
Are you okay? Can you hear that?
We can hear you, sir, but we are not looking at your screen. Yeah, now it's okay. Now it's perfect, sir. Please go ahead.
Okay, so the first thing is there's so many radical prostatectomies being done, certainly in the UK, Western world, and I'm sure in India as well. And strangely enough, there's a higher incidence of Peyronie's disease in these patients. In all patients, about 11 to 16%, but those that actually come to your ED clinic, almost half of the patients will have Peyronie's disease, and we don't know why this is the case. Perhaps it's hypoxia related to lack of nocturnal erections. So that's certainly something that we're doing research on. What about oral therapy? Well, the guidelines say that no oral therapy is of benefit, including vitamin E and PTABA. We've looked into this. We've got an assay looking at the conversion of fibroblasts to myofibroblasts, which is the key aspect of contraction of the plaques. Looked at every single drug that's been used in Peyronie's disease, and the only ones that actually have any benefit, you can see the arrows there, the PD5 inhibitors and the estrogen modulators. So, for example, tamoxifen. So this is where clinical research is, a combination therapy of an estrogen modulator and a PD5 inhibitor in the active phase of the disease only. Xiapex, we had a lot of hope with Xiapex. I'm sure it's exactly the same in India. It's been withdrawn from the Western, well, everywhere outside of North America, really, from a financial point of view. You can still get it, but it's so expensive that it's actually out of reach of most patients, which is a shame, but it wasn't the absolute answer. I mean, these are the studies looking at the efficacy of Xiapex, and you can see, roughly speaking, you can get about a 17-degree improvement in the curvature. So you're not going to make the penis straight, you might improve it, and it's at a cost as well. So where do we go now? Because we don't really have much in the way of oral therapy, we don't have intralesional therapy. So now we're focusing on mechanical therapy. And there is some science in mechanical therapy, and we're talking about stretching the penis. And certainly in the lab, if you stretch the penis, you do see alteration in the collagenase activation, metalloproteinases, all these aspects associated with wound healing. So we do have some translational issues to take it into clinical practice. So here you go, traction therapy. This is the standard sort of penile traction therapy. As you can see, this is in acute Peyronie's disease from Juan Salamanca in Madrid. And if you wore it for 6 hours a day, you can see over a 6-month period, there's about a 20% increase in the curvature and a little bit of extra length. So it's certainly worth doing something, because these are relatively cheap options for patients to have, but they have to be relatively motivated. To tell someone 6 hours a day for 6 months, not many of my patients would actually go with that. There are different stretchers on the market. So this is the PD Master Pro, a little suction device. So goes the penis, the glands goes into that. You can strap it to your leg or your shoulder, or to this spring-loaded gadget that you can see there, just the same as fast size, Jez extender, andropenis. They're all the same. And this again is another study from Madrid, from Ignacio Moncada. And you can see by and large, and this is a 3-month study, and you can see those that actually used it more than 6 hours got a better improvement than if you used it just occasionally. But overall, if you over 6 hours, you can see there was sort of a 50% reduction in the curvature. But again, patients have to persevere with this. The new kid on the block is the Restorex penile traction device from the Mayo Clinic. We don't actually have it in the UK at the moment. It's quite difficult to obtain. So most of the data is coming from the United States, but it is quite good. It's pretty brutal. As you can see, the penis is trapped in that little hinge. And then of course, you can not only stretch it on the bars, but you can also angle it. So you are really giving this, the penis, not only longitudinal stretch, but you're bending it opposite to the curvature. Early results, this is just a placebo controlled study, but of those that did respond, again, it's about 17 degrees. So all of these stretchers improve, much the same as the Xiapex improved by about 17 degrees, but they're not going to make your penis absolutely straight. But if you can actually improve it and stop patients having surgery, then that's a good thing. The other mechanical therapy is vacuum therapy. This is much cheaper. You can get any device. If you've got a 90-degree curvature, you put it in the device, pump it up, and of course, the device is not going to let it bend that much. So you'll again feel the strain of the penis trying to be straightened. So that's mechanical therapy. The other thing that we tend to offer is linear shockwave therapy, low intensity linear shockwave therapy. This is a study from the ESSM, our European Sexual Medicine Society, and all the really good sham versus treatment studies. And I won't bore you with all of the information on that slide, but in summary, you can see there's no evidence that it improves the curvature. There's no evidence that it improves the plaque size. But there was some evidence that if you used it in the early stages of the disease, then the pain would be reduced much quicker. So these are the indications for shockwave therapy, in my view. Yes, if you've got chronic pain, and you do see patients with chronic pain 15, 18 months further out, it's worth giving some shockwave therapy, but it's not going to straighten your penis. We have hopes for stem cells, but unfortunately, I mean, this slide is quite old, and I can't really update it because I haven't got any more information. Most of it's in animals. Most of it is doesn't really give you small numbers. 4 patients in the Levy study. It's now 5 or 6 years old. So I don't really have much hope in this. The other thing is the P-shot, or plasma-rich platelet-rich plasma. Again, there have been a lot of people. There's some nice little gadgets to get this. You just take a blood sample, put it into your machine, and out comes your PRP to inject. It's been used for erectile dysfunction as well. No real data to say whether it works or not. So I am looking forward to this study, which is actually funded, an FDA-approved study from Miami, and you can see randomized double-blind placebo study of 2 injections injected intralesional. So let's watch this space. So let's go on to the surgical aspects. Where are we now? The workhorses are the plication sutures, whether you do a Nesbit, an attenuated, a Yahir, the plication alone, they're all much the same. If you get good results with your method, just stay with it because it's a tried and tested operation. It's been around for, what was it, John Pryor in 1976. So it's a long time it's been around. Attenuated Nesbit, here you can see you're just excising the outer longitudinal layer and you're leaving the inner circular fibers. clearly there's less bleeding and supposedly less erectile dysfunction. I mean, I think this is theoretical because we don't have any information, but it is actually quite a nice way of doing a plication stroke Nesbit procedure. These are the results, and again, all tabulated, different types of procedures, but by and large, at the bottom here, you can see the penis is straight in 90% of patients, and as you would expect, low incidence of erectile dysfunction because all you're doing is putting a few stitches in the back. But of course, penile shortening is an issue. Penile shortening, of course, with Peyronie's disease has happened due to the Peyronie's disease. When you do a Nesbit procedure, if you measure the penile length, dorsally, of course, stretch penile length before and after these operations, it's the same. So you can just say, this is the length your penis is going to be after I've straightened it with my Nesbit operation. The grafting procedures, I think the workhorse is the bovine pericardial graft, which we use because it doesn't contract. Some of the others you can see on this list do. But of course, so the new kid on the block is the fibrin patch or Tacosil. And the reason we like this, of course, is you just lay it on and you don't have to stitch it. So you haven't got this sort of preparation. You haven't got trying to work out what size graft. You just lay it on. I'm yet to be convinced, of course, because some of the studies, as you can see from George Christodoulou, 290 patients with a fantastic success rate and only 10% erectile dysfunction. But I think we do need to see more studies using this. So this is a combined results of grafting in Peyronie's disease. And again, you can see the penis is relatively straight with this procedure. But of course, with this operation, erectile dysfunction can be quite marked. I usually quote 20%, but some studies, of course, have shown 50%. And you have to say it's probably higher because these patients have worse and more severe disease anyway. Because if they have mild disease, you're just going to do a plication or do nothing. The final operation that we have in our armamentarium is penile implants. And these are the issues. Do you put a malleable? And I think in India, you do many malleables. You have a very nice malleable implant, a homegrown malleable implant from Rubin Shah. But then when you do put these implants, what happens when you have residual curvature? Should we make incisions? Should we just model? Should we put a graft in? All these different things haven't been worked out. So you put the implant in, you pump it up, or you got your or you put your malleable in, and you've got a curvature. Most of us would model the penis, and if we can get it less than 30 degrees, that's it. If not, then they go on to incision. And if you've got a big defect, you should put a patch on. Now, this is more studies from Ignacio Moncada, and this is home modeling. So in other words, this is patients in the theater. He got him down to 45 degree, send them home and tell them every day you model the penis yourself for 6 months. And then at the end of the day, 95% of those patients were functionally straight. So perhaps we don't need to be putting incisions in these. Yes, we need to model, but we don't actually need to do all the grafting. When you do grafting, and people like grafting because you say, I'm going to lengthen your penis by doing this, and this is a study again using Tacosil, and it's relatively simple. But of course, it takes longer. You have to mobilize the neurovascular bundle, and potentially, if you've got a longer operation, risk of infection. And this is another study. This is multiple incisions. So rather than just one incision, multiple incisions to lengthen the shorter side, combined with a penile implant. And you can see there a couple of problems, couple of complications, but overall satisfaction quite nice. But if you've got big defects and you put these patches on, the implants are quite forceful, and you can see there, they just herniate out through the patch. So you've got to keep your incisions quite small. And what we're tending to do now is to make multiple small incisions so that you can't get herniations. And actually, if you do multiple incisions together with a little bit of modeling to open them up, you can put a patch on. You don't have to put a patch on, but of course the penis then is more likely to be straight, and you haven't got grafting. So you do have unhappy patients with Peyronie's disease. These are the operations, of course, which have bad press. They are lengthening operations, either doing circular incisions and putting the graft in, the sliding technique, which really has been abandoned, or some of these other things, multiple incisions and grafting to get extra length back in Peyronie's disease. And you are on a hiding when you take on these patients, because you could end up with these. And there's many of these now coming through, not only glands ischemia and losing the glands, they go in for an operation, they come out of hospital without a glans penis. And indeed, we've got a series of 12 patients that have had phalloplasty after penile implant for this complication, particularly in the diabetics. So you have to keep the surgery simple. Remember, a Nesbitt operation is a simple operation. And from a psychology, to mix in with the psychology lectures we've had, if you've got a straight penis and it's a little bit shorter, but it works normally, hey, that's probably quite a good option in most people. And when I speak to my urology colleagues in lectures and I ask them to put their hands up, they all go with plication procedures. They don't go with all of this sort of stuff with grafting. So that's where we are today in 2021 with Peyronie's disease. And of course, we can have some questions later on. Thank you very much.
Thank you, Professor Ralph, for the beautiful talk. In fact, this is an appeal to all the participants that end of this session first, after one more speaker, kindly text your questions through the chat box. That will be taken up by the speakers, our guest speakers. Now, our next talk is by Dr. Sijo J. Parketal. Dr. Parketal is a rare personality. He had his initial career as an engineer. Then he took up medicine. This is a very rare combination we rarely find. He's now the director of Avant Concierge Urology, Winter Garden Apple, associate professor of urology, University of Central Florida. Now, if you look to his antecedents, you know, the qualification is very a combination by which he has been showing a lot of interest in developing the engineering technology as regard the laparoscopy, robotic surgery, and microsurgery, which is applied mainly to the male infertility, the robotic one. He's one of the pioneers in the robotic microsurgery. Dr. Parketal has received numerous awards and published several articles in the field of robotic microsurgery. He is an editor on a few textbooks on male infertility and a surgical textbook on robotic microsurgery. He is pioneer in robotic and office-based microsurgery in urology. Treatment for chronic groin and testicular pain. He is one of the founding board members of the Robotic Assisted Microsurgical Endoscopic Society, that is RAMSES, and is on the foundation board of Florida Polytechnic University, Lakeland. Now, Dr. CJ Parketal will be speaking on a very interesting topic, that is chronic scrotal pain. It is also known as orcalgia, chronic orcalgia. We all have come across orcalgia in our practice, but many a time we are at loss to come to a diagnosis, leave aside the management. So, Dr. Parketal, the platform is yours. Please unravel the enigma.
Thank you. Thank you very much, guys, for the opportunity to speak here, and you know, hope to exchange some good ideas and about this difficult condition. I'm going to start sharing my screen, so just let me know if you see my presentation. Can you all see the slides now?
Yeah, we can see.
Okay, excellent. Yeah, so chronic orcalgia or scrotal content pain is a difficult condition. I mean, but at the same time, very common. You know, all of us in the urology clinics definitely come across some patients that have chronic orcalgia pain. It could be idiopathic or happen after some type of procedure. We see this after vasectomy, hernia repairs, you know, any type of intra-abdominal surgery, sometimes kidney surgery. I've even seen some men after cardiac catheterization develop, you know, groin pain. It can be a varying range of kind of etiologies, but the common theme seems to be some type of irritation along the ilioinguinal and genitofemoral nerve tracts. These are difficult patients to deal with. So most urologists, you know, I tell everyone that it's kind of like we know it exists, but no one really wants to go there, you know. And so the funny thing is I get a lot of referrals for taking care of patients like this because you know, it's difficult. We don't have a quick, easy fix solution. And so these tend to be some challenging patients. What I'm going to present here is just some concepts of how we could think about approaching these patients. So I have no disclosures. The talk's going to start with an introduction, pathophysiology, some assessment tools, and then the treatment algorithm I use and some conclusions. So what's the definition of chronic orcalgia? Now, I'm not talking about the individual that comes in with epididymitis or an acute infectious process or torsion or any of these common issues. We're talking about individuals that are having chronic pain. They've been worked up. We've done some imaging. We've done a physical exam, and still there's no definable pathology, but and conservative treatment options aren't working. So we've tried antibiotics, we've tried anti-inflammatories, and they still have persistent pain. These are the individuals we're talking about. When you look at some of the recent studies, we think that chronic scrotal content pain accounts for 2.5 to almost 5% of all urology clinic visits. Now, when you think about that, that's a huge number of patients. So it definitely means that each and every one of us has probably seen one or two of these patients, during our clinic weeks and the regular patient clinics. What's the pathophysiology? So I just, Oka et al. Have done some really cool studies looking at the neuroanatomy, using electron microscopy to show that there's a real complex interplay of nerves in the spermatic cord. So unlike the old Netter textbook, images, it's not just one or two nerves. There's a whole plexus of nerves in the spermatic cord. And so it's not one discrete nerve, but it's a whole interplay of different nerves. Now, how does that apply to patients with chronic testicular pain? I did a study about 10 years ago where I took about 50, 60 guys who had chronic pain like this, and then 10 healthy controls, guys who had no pain, but were operating for other reasons. So for example, guys who had a testicular tumor, but didn't have pain and were removing their whole cord, or individuals who had a varicocele, but had no pain. That was our control group. And what was interesting is we did biopsies, kind of staged biopsies on the spermatic cord while we were operating on these individuals. So it was quite time consuming. It was a prospective study where I compared men with pain versus those that didn't have pain. And, I had a pathologist doing real-time intra-op analysis for me to see if certain areas of the cord had nerves, if these nerves look normal, if there's any abnormalities. And so it would take an additional 1 or 2 hours for each of these procedures. But we garnered quite a bit of data because this is the first paper that actually has really looks at men with pain versus those that don't have pain. And what we found was in about 84% of the guys who had pain, there was Wallerian degeneration in 2 or 3 specific nerve locations in the spermatic cord, compared to only about 20% in the control group. So this is the first paper that shows that there is something structurally different about these individuals compared to healthy normals. And what's interesting is this change in the nerves ranged across these individuals. So it was men with post-vasectomy pain, men with post-inguinal hernia pain, idiopathics. They all had the same type of nerve distribution, which tells us that maybe there's something different about these individuals and it has less to do with how they came about with the pain, but maybe it's a combination of having these abnormal changes and then some type of traumatic event. These 3 locations were in the cremasteric muscle layers around the cord, the perivasal sheath, that's the sheath right around the vas deferens, and then the posterior fat behind the spermatic cord right outside the internal spermatic sheath. I then did 3 or 4 cadaver dissections to confirm whether I could find this plexus of nerves in a cadaver. Now, in a cadaver, it's a little trickier because there's a lot of fat suppression in some of the embalming process, but you can actually see the nerve plexus a lot easier because the fat kind of convalesces and kind of sticks to the nerves. So it actually confirmed that we have this, what we call trifecta plexus of nerves. So this may explain why some patients have pain versus those that don't. Now, how do we assess patients who have pain like this? It's very difficult to measure how this pain impacts individuals because when you just use the visual analog scale of 1 to 10, it might be difficult to capture how much it's affecting them. So Polakowicz and Dr. Shasky in collaboration with us developed a quality of life kind of scoring system called the COSI. It's called the Chronic Orcalgia Index Symptom Index. And basically, this is what it looks like. It's available online, and if you guys are interested, feel free to reach out to me, and I'll be glad to send it to you. It's basically just a 12-question questionnaire, very simple. Has a few questions on pain in terms of how frequent it occurs and the intensity. It's got a few questions on sexual symptoms, because a lot of times the pain affects individuals in terms of their sexual function, and then has 3 or 4 questions on quality of life. So it tries to capture pain, sexual, quality of life impact, and ties it all in together. And this has been externally validated. Shasky et al. Followed up with a study testing at a few different centers to validate the tool. So this is a tool that you can use to measure, testicular pain. So now moving to the crux of it, what's our treatment algorithm? Well, what we did is not only have we summarized some of the evidence that we've published, but we did a PubMed query looking at all the terms for chronic orcalgia, testicular pain. This was completed on April 1st, 2020, and we reviewed about 2,400 articles, and then kind of summarized and tabulated all the results together to try to come up with a kind of overall algorithm. So this is the algorithm. And I know I've broken all the rules in terms of putting a lot of data on one slide. And so I apologize, but and I'd be glad to share this with any of you guys. And we published this in Research and Reports recently. But I'll walk you through this. And this is the crux of the talk. What do we do when treating these individuals? So you've got an individual who's had chronic pain for more than 3 months, and they've failed all the conservative treatment options. What's the next step? Now, if they have pain after a vasectomy, one option is vasectomy reversal, especially if they have congestive type pain symptoms. So if the pain symptoms seem to get worse after ejaculation and lingers for a few hours and then disappears, vasectomy reversal actually works fairly well for these individuals. And the published success rates are anywhere from 69 to 100%, depending on the study size. So that's a separate group, post-vasectomy pain syndrome. One of the initial things you could try doing is a vasectomy reversal. Now, how about the standard guy who's idiopathic or other modalities such as post-hernia pain or any other type of chronic testicular groin pain? Well, we would first start out with a targeted cord and or ileoinguinal block. Generally speaking, we tend to do our blocks under a little bit of IV sedation, because some of these individuals are very, very sensitive to begin with. And so if you try to inject lidocaine and marcaine right into that painful cord, a lot of times these guys jump off the table, they have a paradoxical increase in pain, and you'll never see these guys back. It's very traumatic for the patient and for the physician. So we tend to do the blocks under a little bit of IV sedation because it kind of calms them down. It lets you do a better job, and we can actually inject more medication. My standard block is a mixture of 15 cc's of 1% lidocaine, 15 cc's of 0.25% marcaine, and 8 milligrams of decadron. So it's steroids, lidocaine, and marcaine, and it's a large volume, about 40 cc's. And the reason we put this much is we're going to bathe that cord completely. When we do a cord block, what we're doing is injecting a portion of it, a few cc's right next to the vas deferens, since that's where a lot of these problematic nerves are. And then the rest of it, I just stick my finger in the external ring, and we put the rest of the block medial and lateral to the cord. So that way you protect the cord, and you're actually just bathing the entire spermatic cord. Doing it this way, we almost get like almost like an 80 or 90% success rate in terms of relief and pain when we do the block this way. Now, the block has a 78% positive predictive value in terms of telling you the individuals that might respond to targeted or standard microsurgical denervation of the spermatic cord, which would be the next step. So if they respond to the block and you get temporary relief in pain, the next step is standard or targeted microsurgical denervation. The success rates range anywhere from 77 to 100%. We pretty much do something called targeted microsurgical denervation. So this is different from the classic denervation procedure where surgeons would cut through the whole cord. We're only going to ligate the cremasteric muscle layer, the sheath around the vas, and a little bit of the fat behind the cord. So it really looks like you haven't done much on the cord. And this way it minimizes the risk to the patient. You you pretty much leave the internal spermatic sheath intact. You don't mess around with the arteries or veins or anything like that. And the reason is that we found that there's not many nerves around those structures. And so there's no need to put this patient at risk of losing the testicle or doing anything majorly invasive in these individuals. And that way there's less risk of a hydrocele or, lymphocele or lymphatic, swelling, right, like that post-op. It makes this procedure much, much simpler. If this, we tend to get anywhere from 80 to 85% success rate with that procedure. If that fails, the next step is something called ultrasound-guided perispermatic cord cryoablation. This is where we put a small percutaneous probe medial or lateral to the spermatic cord, and now we're going to attack some of the nerves outside the cord, and that has about a 70% success rate. If that doesn't work, we can do Botox injections. So now we do a block, but we just add Botox as well, about 100 units, and that has about anywhere from a 60 to 70% success rate. If that doesn't work, we can try peripheral nerve stimulation. That would be the next step. They have these new implantable stimulators that you can implant in the groin. That has about a 60, 70% success rate. And if all of these fail, then obviously the last option would be, orchiectomy or, epididymectomy and some of those options. The success rates vary anywhere from 20 to 75%. But the one issue is that there is a risk of phantom pain in these individuals. So, and that's why I think before you jump into taking out the whole testicle, the epididymis, it might be better to do some of these targeted therapies before we jump into those kind of aggressive removal procedures. If all of these fail, or the individual develops phantom pain, one option may be coming back to cryoablation, or there is something called targeted robotic intra-abdominal denervation, where we can go inside the abdomen and basically skeletonize the gonadal vessels. So we're essentially ligating the infrahypogastric and the genitofemoral nerves inside the abdomen. And that has about a 60, 70% success rate. However, I've had 1 or 2 patients develop leg pain post-op, because then it kind of makes sense, because some of these individuals may have complex regional pain syndrome. So if you shift some of the nerves that are more medial, now what's left is some of the femoral and lateral nerves. And so the pain may shift to that area. So the intra-abdominal neurolysis, I'm not the biggest fan of that procedure, and has some risk associated with it. So, it can make things worse. And I've had 1 or 2 patients where, they develop leg pain after that. So that procedure, is kind of a last resort if there's no other means. If any of these fail, then we go back to chronic pain management, sacral neuromodulation, blocks, physical therapy, acupuncture. We kind of go back and forth. Now, generally speaking, surgery should only be used once you've kind of exhausted all the conservative measures. They've tried physical therapy, acupuncture, all the conservative medications. And then if it's still persistent, that's when some of these surgical therapies may be of benefit. So in conclusion, chronic scrotal phantom pain is tough, but it's common. We're going to come across some of these patients. And so it has a significant impact on the quality of life of these patients. When we were setting up the COSI score, we found that the impact of chronic scrotal content pain is almost as equivalent or greater than, like, for example, somebody living with Crohn's disease and has to have a bowel resection, or somebody with chronic back pain and having back surgery. So it is quite a significant impact on the quality of life. And there is evidence-based data now to support a structured treatment approach for patients with CSP. And with that, I'll kind of end my talk.
Thank you, Dr. Sijo. In fact, while unraveling the enigma, a lot of queries has come up. I think please stay on. Start the question answer session right away, starting from you. Can you please unshare the screen?
Okay, let me just switch to, I'm going to stop share. Yeah, there we go. Yeah. Okay, perfect. Okay.
Well, a lot of question has come to you because you are trying to unravel the enigma.
Oh yeah, so as far as I know, okay. Okay,
The first question.
Yeah, is degeneration or regeneration after degeneration, which is the cause?
Let me ask the question.
Sure.
Dr. Joseph Philip Raj, he has asked, is it degeneration or regeneration after degeneration, which is the cause of orchalgia?
What we found was Wallerian degeneration in the study, but you're right, absolutely, because regeneration can also cause neuromas. And so in some of these failure cases, especially after we do a ligation procedure, so a small percentage of these patients sometimes develop pain a few years later. In that situation, probably it's regeneration, because now there might be a neuroma or a tuft where we did procedure. Now, the other possibility is that these individuals have degeneration to begin with. Then, for example, we do a vasectomy and we're cutting that abnormal nerve. And then in the regeneration process in this abnormal nerve, now they have unexplained pain. So I totally agree. I think it's both. There's probably a component of both of these going on that's causing the pain.
The follow-up is, what is the rationale of infiltrating previously local anesthetics? Try and see if degeneration theory holds good. Is it due to non-neuroinflammatory phenomena?
It could be, but the problem is that it definitely has an acute phase response, because that's why some of these blocks do work for a short while. But generally speaking, when you follow these patients several years out, even if you do a series of blocks, many of them fail. And so there's probably an acute inflammatory process, but there's also some type of baseline functional problem with the nerve. And that's why I think denervation does so well.
I think there is one very interesting question from Dr. Prakash Kotari. Which approach is used for spermatic cord denervation, and how to confirm intra-op that the denervation is complete?
You're right. Intra-op is very difficult because these nerves that we found were on a kind of scanning microscope or H&E staining on pathology. So we wouldn't be visually able to see them just yet. So right now, what we do is we're going by anatomic dissection. So we're just cutting the cremasteric muscle there, stay outside the internal spermatic sheath, and then you take just the sheath around the vas deferens while preserving the deferential artery, and then some of the posterior fat behind the cord. And we've got some videos online on our YouTube channel that you can feel free to check out. So it's actually a very simple procedure. You're not cutting much, and that completes the denervation. There are some new technologies in the works, like optical coherence tomography, real-time imaging laser kind of scanning technologies that are probably going to come within a few years, where you can actually directly real-time see nerves. And you could use those same scanning technologies to do high-focused ablation. So the theory is, in the future, we might be able to actually see the individual nerves and ablate them. And then that would tell us exactly how well we're doing with the denervation. But right now, unfortunately, it's just based on gross anatomy.
And finally, kindly briefly answer, is STRAT so selective? Won't there be any inadvertent anesthesia in the region?
I beg your pardon, what was the question again? Sorry.
Is STRAT so selective? Won't there be any inadvertent anesthesia in the region when you are doing a trial?
There is, but you mean from the IV sedation, right? I mean, I think that there is, but the key is if they get some temporary response for a few days or 3 or 4 days, the cord block, and we've done this study looking at like maybe 1,000 or 2,000 individuals, it has about a 78% positive predictive rate to guys who are going to have a positive outcome from denervation. So there's something above and beyond just placebo effect. My feeling is that, for many of these guys, there is some structural abnormality, and that's how, they get response from the targeted denervation.
Thank you. Thank you. I think one question which Professor Ralph has already answered, he can come in and or he can directly answer the question. What is Dr. Ralph's opinion on intracerebral injection of verapamil? Dr. Ralph, Professor Ralph.
Yeah, I think
you answered it, but you can, yeah.
I use verapamil because we can't use Xiapex anymore. And so I do use it. It's a 4 ml solution which you inject multiply into the plaque with a blue needle. I guess the same as Larry Levine, sort of 15 degrees improvement. I guess you can combine it with traction therapy. I mean, you think you have to combine it because you can get 15 degrees with all the tractions without having to do all the injections. But it is good. As you can see, Shri was saying, it's quite good for pain. It has a reputation of being good for painful Peyronie's disease. You inject the verapamil. So there's still a role for it.
Thank you so much. There's the next question from Dr. Joseph Raj. Does the stretching devices, when in use, correct erection at the side effects?
Well, I answered that you shouldn't be getting erections when you've got the machine on. But I don't think it makes much difference if you do. But all the reports say that actually the IAF score increases after traction therapy. I'm not sure the rationale behind that, but you know, it's quite a safe piece of kit.
One question from Dr. Prakash Kotari: what should be the schedule and dose of verapamil?
What should be the what? Sorry, with verapamil?
Schedule. What should be the schedule and dose of verapamil?
The doses, it comes, well, certainly in the UK, it comes of 2.5 milligram per mil. And so I give 4 vials, so that's 10 milligrams in a 4 ml solution, in a 4 ml bolus. So, and then you inject it under local anesthetic with a lignocaine block. And then I put a compression bandage around to try and reduce the swelling and get them to do home modeling once they get home, or the next day.
Thank you so much, sir. I think many questions have been answered. Thank you for contributing in the enlightening all those aspects on Peyronie's. If permitted, we can go to the second session. We are just on time. We are almost 8:40 now, 10 minutes. You know, we are late. So can we switch over to the second session? Our second session is panel discussion, another interesting topic, which is not discussed very often. It is unconjugated marriage. And with me, I have got a panelist, all luminaries. They are very expert in their field. Unconjugated marriage, as all of you know, is hardly discussed. And many a time we are in difficulty how to understand the cause of unconjugated marriage. And then when we plan out how to manage the case. Now, unconjugated marriage, as you all know, the definition, there is no definition. And what is unconjugated marriage? Unconjugated marriage can be defined as a failure to perform successful sexual intercourse at the beginning of the marriage. There is many definitions to that. Unconjugated marriage, honeymoons or wedding night importance, first night erectile dysfunction, and failure of defloration is a common medical and social problem facing medical practitioners in the conservative communities. Unconjugated marriage is a disorder in which couples are unable to achieve penile vaginal penetration despite regular attempts in a certain period of time. Some people have tried to quantify the time to 3 months, but you know, we never know that. So what is non-conjugation? Whether it is non-conjugation with first attempt or with multiple attempts, the duration may vary. Now, the most favorable one that I could find out, unconjugated marriage is a formal marital relationship in which penile penetration of the vagina did not take place, and the situation is a source of stress for either or both spouses. Literature shows variety of causes, you know, ignorance and you know, not having knowledge about sexual life and sexual organs. There is small vagina, fear of pregnancy or childbirth, impotent husband. The sex act was considered to be nasty or wicked, fear of pain during initial intercourse, extreme dislike of the penis, dislike of intercourse other than for procreation, dislike of contraceptive, dislike of semen. So many causes have been ascribed to the non-conjugation. Now, to discuss all these aspects, I have with me very, very eminent panelist, Professor P.C. Mahapatra, who is the past president of the FOXI. He is my colleague. He retired from SU Medical College as professor head of the Department of Obstetric Gynecology. We have with us Professor Shivam Priyadarshi. He is presently the professor HOD of Urology, SSM Medical College, Jaipur. Then we have with us Dr. Vinod Kebi. He is joining me from Trivandrum. Dr. Raman Tanwar, he is from Delhi. Dr. Pramod Krishnappa, he has joined from Bangalore from the NU Hospital. Now, we would start with some real life cases and how to go ahead with the evaluation and management. We have this first scenario. Couple, husband 41 years and wife 32 years, married for 6 years, presented to obstetric and gynecology specialist for infertility due to family pressure. Gynecologist did the initial evaluation of the female, which was normal, and referred to andrologist for evaluation of male. Now, what is the approach to this case? Professor Sivam Priyadasi.
Hello. Thank you, sir, for giving this opportunity. So definitely this is a case of infertility, and we need to evaluate in terms of this infertile couple. The female has been examined already. The male has to be examined with a proper history. And the history, I think we should include history of medical illnesses, any drugs consumed, any history of surgery. And then in puberty, there was was it a delayed puberty? And then the socio-cultural background of the person, the educational, religious background, and most importantly, the sexual history, which would include sexual orientation, the patient's sexual behavior, his desire, his orgasm, ejaculation, erection path, and also the fantasies and the sexual abuse if he has suffered in the past, the body image and the interpersonal relationship between the two partners. So I think these history is very important to find out exactly the cause in this patient who is not a very young couple. And then we should go forward with the physical examination, focusing on the genitalia and the secondary sexual characters, and followed by some investigations. Particularly, we need to do a semen analysis, definitely, to find out if the semen is normal. So I think in this way, we should go ahead to know the exact cause of this infertility.
On query, the husband says he enjoys the foreplay, has a good erection, but on attempt at penetration, it becomes passive. The importance of relevant specific sexual history. Anything further you would like to take?
Yes. So as I told you, the history is very important. In this case, probably the sexual history, because he said, but on attempted penetration, his penis becomes flaccid. So it could be either he is not maintaining the erection, or probably he is ejaculating so very soon so that he is losing the erection, or the patient may have, the female may have some type of pain. So if as soon as he touches the vulva, the patient loses erection, or is not, doesn't allow, the female, the partner doesn't allow. So it could be any of these.
Now, he immediately ejaculates. On inquiry further, he mentions that he immediately ejaculates in each attempt before penetration. For last 4 years, he is neither having erection nor ejaculation and has stopped sexual intercourse. Dr. Vinod, how would you further proceed in this case?
Yeah, this is a typical example of a case where a premature ejaculation is finally turning into an erectile dysfunction, and finally the couple remains unconsummated for a long time, and instead of a husband and wife, they become brother and sister. So this is one of the typical presentations in the our andrology clinics. Here, the first thing we have to discuss with this patient is about his a detailed sexual history, and in that part, what we'll be focusing is the his stress which is instigating the problem, especially the stress of the society and the family for having a kid and things like that, and also the impression of the wife about the problem. So a detailed history of the with the couple and their aspirations have to be taken care before we venture into the treatment of this particular problem. What I personally feel is, if the family pressures are very high and the social stress is very high on having a kid, when we are going to treat the patient, we may not be able to take out the stress fast. It may take some time. It becomes.
I will come to that, Dr. Vinod. I'll come to that. At this stage, I will mention that the patient examined by the andrologist is physically normal, he is genitally normal, and the only thing is that he has developed a secondary ED following his premature ejaculation and failing to consummate. Now, how would you like to manage this case, Dr. Raman?
So, sir, I think in the management, first and foremost, I want to identify whether his premature ejaculation is actually something which is pre-existing or it has been something which is just a result of stress. So basically, two things I want to divide this premature ejaculation into. One, is it primary or a secondary sort of a premature ejaculation? Has it been there because the patient has been having a genetically low level of serotonin, or the conditioning has been such, or is it secondary or acquired, which is happening because of stress? That's like Dr. Vinod KV said. And I would also want to decipher with the with the course of history taking only, and sometimes even with medications and a follow-up visit, whether actually the premature ejaculation has a central component or it has a peripheral component. So of course, examination, as you said, was all right, because many times we could find faults there as well. But this is my basic strategy. So I have to counsel the patient then that if this is that ED is basically because of premature ejaculation. So that is something that I have to also tell them and understand the correlation between ED and PME.
Yeah, this is as we go through the case, this individual, it is a secondary premature ejaculation, because this man was telling earlier in the masturbation he was able to hold the ejaculation. Now with the wife he is not able to. And over 2 years of time, when he could not go for a penetration, he gradually lost his erection also. In this situation, how would you like to manage?
So, sir, first thing that I would want to clarify here is that, how he held the ejaculation during masturbation, may not be exactly related to his, having an intimacy with the partner, because as per the definition, PME would not necessarily be defined based on what his timing at masturbation was. But yes, of course, here, in management, I would like to, counsel the patient about why this can happen, considering it most likely to be a secondary case, and then, start him on a combination of both, the medicines for the premature ejaculation, which include SSRIs and depoxetine, and also some inhibitor.
There is a network problem at your end. Wife says there is heavy domestic pressure and would like to have a child first by ART. He is demanding and he is coming to you and he is asking to have a child first, then taking care of the non-conjugation. Now, how do you like to manage, Dr. Krishnappa? Pramod?
Yes, sir. Sir, I feel they're still young, and if they don't have any family pressure, then we shouldn't push them for ART, as long as the couple are okay to accept that they have more time to have children. And if this is a case of premature ejaculation, I know Dr. Prakash Kotari may not be happy that we urologists keep using this premature ejaculation, but whatever it is, I would like to treat this patient, because at the end of the consultation, a patient always wants a solution. So my first preference for premature ejaculation would be starting him on a low dose of PDE5 inhibitor and to instruct him to do a stop-start therapy, so that both the ED and premature ejaculation can be taken care. And I would not force the couple to undergo ART as long as they don't have any family pressure.
He says you have tried this PDE5 inhibitors with SSRI, but he says he still doesn't have a good erection. Yeah, good. For the erection, again, it's a different topic, sir. If the PDE5 inhibitors are not helping apart from counseling, so then we move on to using intracavernous injections. In this case, we have to address both. His ED and PE, both has to be addressed. How do you like to address this, both the problems? Yeah, I like try all other options of premature ejaculation. Like we can use the local anesthetic creams over the glands, which can be applied 30 minutes prior to the intercourse. So that premature ejaculation can take care with that. And if PDE5 inhibitors are not helping, then maybe basically you will need a combination therapy in this case. Right. Now I'll request Professor P.C. Mahapatra to please come in with the same thing. Wife says there is heavy domestic pressure and would like to have a child first by ART. What would be your advice, sir? Professor P.C. Mahapatra.
Well, in this case, I think
Thank you very much for involving an odd man out in this international seminar on Urological Society and speaking on a subject on unconsummated marriage. That's why I came into picture. Well, if this patient has come to me, I will ask one question to the couple, that you are married for 6 years and you have come to me only by family pressure. You want a baby for the family or you want a baby for yourself? I think that's a very important thing, and counseling plays a very important role in that. And all infertility patients, I always say that the sexual history and the coital history is absolutely mandatory. I always tell my gynecologists that you do all the evaluation, whatever evaluation has to be done. But I think the tech and touch is different. You apply the test and depend on many tests and all that. Rather speak for many times, more hour you spend on discussing the problem, and that could be solved. Majority of this type of problem, I think, can be solved by counseling, not by the medications and all that. So that's a very important thing, which importance of sexual history, importance of infertility. If segregation from that, if you want sex is not required, only child is required, and you do an ART, I think some of the patients in current scenario are asking for that also. Even they say that we can ignore the sex, forget about it. We are satisfied 6 years. We are living together and in the different rooms and all that, but we want a baby. And in that particular situation, ART has a place also. And there are many people, and that is one place. Second is, if you cannot give justice and you cannot relieve the husband of the problem, then of course the ultimate solution is an ART for that. So first of all, I will agree with the Binod and Pramod that treatment is justified. You treat the patient, and if there is a failure in desperate cases, I think that there is a place for ART. Now, would you succumb to the pressure that they are very much in need of a baby, or would you like to give therapy and referring to an andrologist?
Both. I think you have a marital marriage means you want, I will serve the functional aspect also. It's not that baby is alone important for that. So both child as well as their functional status as regards sex is important for me.
So which one will be given priority out of these two?
Both I will tackle. I think first priority will be given to find out, to correct the abnormality, because the patient is not very old. I think if it would have been a 35 plus and all that, I would have gone for ART first. Otherwise, the age nowadays, people are career seeking women and all that. Age is a very important factor and all that. We cannot prolong it, but at least this cannot be completely ruled out in the current situation, current scenario, in the present context, that ART has a place. But simultaneously, I will find out a solution for the male. And predominantly, these are the cases. Majority, what I have found, that counseling plays a great role on that. It's not that, and unfortunately, we find, I think you are the moderator, you know very well in the state of Orissa, how many people how many urologists are andrologists. I think to get a good andrologist is a $1 million question for us. And the time is important, the unrewarding. Urology practice is rewarding, but andrology practice is not rewarding, and that's why you people are not interested in that.
I'll come back to you again, Pastor Sibam.
Yeah. So I would like to say that, yeah. So when the unconsummated marriage is prolonged, it should be taken as a semi-emergency, because the longer the unconsummated marriage, lesser the success rate for any treatment. So this should be treated as a semi-emergency, not only counseling, but and only oral drugs. Particularly this case may require intracorporeal injection as the first treatment, because that will break the ice in this couple. And this will not only help to improve, to have a good erection, but also even after ejaculation, the erection will continue. So the patient may have good penetration, penovaginal intercourse, and the fertility issue can also be solved. And once the patient develops confidence, then these injections can be replaced by oral drugs. So I think this should be taken as a semi-emergency and need to be treated in a very proper manner.
Dr. Vinod, as
sir.
per your saying, I think the couple should not live like brothers and sisters, and I put it the other way around, that a man and a woman staying together. They should have a conjugal life and they should conjugate. Now, from that point of view, would you recommend, as an initial approach, would you recommend for a ART?
Sir, I get two categories of patients. One category is even after 1 year of married life, the family is putting so much pressure on that couple to get a kid. And another group is they are trying with so many things, and after 4 or 5 years, they are presenting to you for a problem like this. So in the first category, I tell them, you tell the family that, or tell your friends that we are going to have a kid only after 1 year, and you get treated for this premature ejaculation, erectile dysfunction, and things like that, and get it sorted out and have a kid after one year or 2 years. But in this case, when already some 4 to 6 years have gone and the family is putting so much pressure, whatever treatment I provide to them, they will not be happy, and they will be overstressed. Every month will be a stress for that lady, and that will reduce the chance of fertility. So I will prefer a ART if they are opting for that in such a patient, such a couple who is so much distressed. And I have tried giving treatment for such patients, and none of them have so far succeeded.
What was their afterwards, the follow-up? Could they have sex after giving the ART baby? Because when you have done an ART, basically the problem arises whether they can have the regaining the sexual activity or not. So that's the issue. So
that is
finally, finally, building the basis, whatever we have discussed, severe premature ejaculation resulting in unconsummated marriage is not uncommon. All steps should be taken for consummation rather than initially trying to go for a ART and providing the baby, even if there is a demand, which includes use of ICVAC and SSRI. What Professor Shivam has told, the PDE5 inhibitor in these patients who have already had non-conjugation for 6 years may not be very beneficial. We need to have a confidence building. There has to be positive reinforcement demonstrating a good erection which is sustained. So for that reason, we have to use ICVAC. And for the premature ejaculation, it takes a little session. We should have good counseling. We use the ICVAC. The man gets back the confidence in due course of time, and the SSRI might help as regard the ejaculation is concerned. So what he has to learn is the first is the vaginal containment. So we should take all steps as regard the resuming the sexual activity, because fertility is totally a different issue. Under social and domestic pressure, they are asking for a child. But if it can happen naturally, so far so good. And ART should not be advocated in the initial management. That is what I would like to summarize from this end. Now, any other view from anybody else is welcome also from our panelists. Professor Mahapatra, would you like to say something at this juncture?
I think both should be, addressed and all that. It's not that ART should be done in the first setup for that, but we are concerned both for fertility as well as for sexual function and a good marital life. That's important. And we must try to find out the cause for that. And many cases you say that, as Vinod told, that none of them is successful. That means there must be some cause. That means either it's an idiopathic. I feel that idiopathic, I'm very averse with the term idiopathic. When the doctor is an idiot and patient's condition become pathetic, it is idiopathic. And therefore, I think we must find out the cause for that.
Sir, actually, those cases where patients who are married for 4 to 5 years and trying for further multiple treatments and then coming to us. For the couples who are married for 1 year or 2 years, we can treat. But not a patient like this who has been on treatment for 4 to 5 years or trying for a kid, doing multiple treatments. They will be too much resistant. That is this is a different situation. Not
Okay.
like
I think Dr. Hota, you have raised a very important point that if ART has been given and they are successful after the baby, whether the normalcy of the sexual function will be regained or not. I think that's a very pertinent question.
So that is what that is the crux. In fact, that is the crux.
That's an important thing for
You
that.
know that
Because
all
organic thing will not be solved, but functional thing can be solved for that also. Otherwise, there is another issue could be there.
Yeah, that's the reason, in the initial evaluation, we do not think about the fertility aspect of it. We always look to the potency part of it. Whether the man can have an erection in an office test, and office test is better performed with the ICVAT rather than a PD5 inhibitor. That's the message I wanted to give. Thanks to all of you. This has generated a lot of discussion. There is no consensus in many situations. The opinion differs, and particularly when a gynecologist and an andrologist are there, the opinion are likely to differ more and more. We go to the next case. Now the scenario 2, this is again another life scenario. 29 and 26 years, husband and wife from a remote rural area, married for 2 years, referred from gynecologist for a male factor infertility. His evaluation of the female is normal. On evaluation, the husband has no physical abnormality and he has good erection during masturbation. Wife on inquiry says that she doesn't experience any penetration during the sexual act. How to evaluate? Dr. Raman?
So can we again go back to the first slide, please? Because I think it moved too quickly for the audience.
Yeah, please.
So basically here, what is happening is that basically the gynecologist has sent us because the wife has told the gynecologist that she does not experience any penetration during sexual activity, which again the gynecologist's perspective is that the female is normal, and the husband as such has had good erections during masturbation. So we know that the male from our perspective is also normal. So coming back to the evaluation of this, I think of course, again, we have to dwell deep into the history and examination and basically, ask both as an individual interview and also as a couple interview that, what exactly has been happening behind the scenes, because this is just a version that we are getting. So basically, now in the evaluation part, basically we have to understand that, erection has to be assessed in all the domains. The morning erection has to be assessed, the masturbatory erection has to be assessed, and also the erection during consummation has to be assessed. And of course, we can start with something like a basic history and then do a office sildenafil test also. We can just pop in give a pill to the patient and, ask him to elicit the erection there. But basically, even if we get a real erection there, it doesn't mean that it may not be a psychogenic ED happening with that particular partner because of numerous reasons. The performance pressures, how the partner is perceiving it. So all those kind of things are something which can really happen. And then, it will be very difficult to understand that because we're not actually witnessing the act. We are just taking the history, and history can be modifiable. And there can be, in such a couple who is fighting, there could be allocation of resources of blame, saying that this doesn't happen, that doesn't happen, the wife doesn't do it this way, the husband doesn't have the potency, and then it becomes an ego issue. So I think first we assess it from our side, saying that with the office sildenafil test, or maybe if required, maybe just office biomix test, and take it from there.
Dr. Raman, he was physically found to be normal on physical examination, and office sildenafil test produced a good rigid erection, and husband was advised to use the sildenafil for sex. Husband comes back and says there is no difference, which is endorsed by his wife. And his wife also says that he is having erection, but we are not having any penetrative activity. What are the other possibilities that you can have in mind?
Right, sir. So then again, a new set of possibilities will come in. One is that, there is a problem with the wife and in terms of vaginismus, but the gynecologist has already examined. It was not basically in a situation which was, the real sex. So here again, I have particularly noticed that the gynecologist would put in 2 fingers and say that, there's no vaginismus. But basically the situation also matters, who is putting the finger and what is going inside and at what time it is happening, because the office situation may be different, but there would be some other psychological cause behind it. It would not be just an anatomical narrowing which would be there. There would be the fear, the stress, all those reasons that we talked about.
No, he doesn't have ED. The fact is that he doesn't have ED. Both he and wife both are endorsing the penis is erect, but we do not
Right.
have any.
Apart from that, we also have to, understand how they are doing the act, because as you yourself, pointed out in the first few slides, that there is requirement to understand how the activity happens. So
Very
sometimes,
correct.
the husband and wife may have no idea how to do the activity.
Okay, very correctly said. Our gynecologist colleague, can you please tell your viewpoint? What could be the reason?
I think these are very common. See, in 40 practice of mine, I routinely take a sexual history. Believe me, there was a lot of hesitation amongst the gynecologists to ask about sex and all that, particularly in country like India. But what I find that if you give a hint that sexual history and all that, they come forward and speak more and more about it. And the ladies are even uneducated people also, they do not feel shy to express if they know that the consultant is asking about this and all that. And majority, what I find, if everything women, I will try to examine the female, find out whether there is any pathological thing or not. From the history also, the pain, dyspareunia, and on examination, I find that there are cases where I have found there are cases of vaginal atresia, complete vaginal atresia, and it's not possible for that, for consummation and all that. That's one. And introital tightening and just admitting one finger and all that, that could be another possibility. But majority of the patients on examination, it's normal. Examination, it's normal. And
let me come here, sir. In this particular case, most important is to know, because if you go back, I mentioned that they are from a rural background.
Yeah, ignorance of the sex act is also a part which is important. They do not know. That is important.
Because we had taken care of the erection part of it, and we knew that he had produced a beautiful erection, rigid, sustained erection with the sildenafil. With sildenafil use also, there was no penetration. So therefore, should we go on questioning the husband is unaware about the act of intercourse and has a vague knowledge about female genitalia. Now, this is how common is the lack of sexual knowledge a cause of unconjugated marriage? Dr. Pramod?
Yes, sir. I think Dr. Mahapatra said already told about this, how common it is in the rural areas. I, practicing in a metro city, I do not come across very often these cases, but yes, occasionally here and there, we occasionally come across such lack of sexual knowledge being the cause for unconsummated marriage.
Now, Dr. Shivam, your experience?
Yeah, I think this is not very uncommon, and not only in rural areas, even in urban areas also. I would say that because in our traditional society, many of us, many couples will enter arranged marriages without any kind of sexual experience. They are almost both are virgins. So it is possible that many a times that they are totally ignorant about the sexual act. So it is very pertinent for the physician or the examining clinician to understand whether the partners know exactly about the sexual act, particularly in such a situation where they are having the male partner is having good erection, no premature ejaculation, the female is not having vaginismus, the gynecologist has already examined the patient, but still they are not having penetrative sex. So then definitely we need to rule out this ignorance part. So I think it is important.
Yeah, they were sent to a counselor and were given detailed dummy demonstrations, came back after a month still unconsummated. Well, Vinod, what should be done at this situation?
Sir, actually, this is one of the typical presentations of unconsummated marriage. See, whenever we see a patient and ask for a consummation, the first thing will be the husband will be telling that he is doing penetration. But we always should ask the history from the female, whether she's confident that there is penetration first. Sometimes they may not be happy in revealing that. Then we have to ask whether there is wetting of the vagina. And some patients may not even tell that because they don't know. Now, the next question is we can ask them, are you seeing some semen coming out of vagina after the intercourse? So these are some indirect questions which will point us to the fact that she has a penetration happening. Second point, I want to prefer a office sildenafil test for a patient who is having a normal masturbation, normal erection, apart from the intercourse part. And third point, in such patients, the problem will be their lack of sexual knowledge about the anatomy, the female anatomy. They may not be aware. Both the male and female may not be aware. And the second problem will be their position. Especially in obese patients, I have seen penetration being claimed by the husband and wife is not sure about that. And they are having penetration in between the legs. And also in some of the patients, I have seen patients claiming that there is some penetration, but it is happening between the majora, labia majora. So no penetration has happened. So in such patients, a proper advice about the different positions they can take. Even examining the partner's vagina may help that patient to see what is happening. Even using the finger dilatation of the vagina so that he will know what is the direction.
We'll come to that. Dr. Vinod will come to that.
Dr. Hota, I think.
Can I ask Vinod one question?
Dr. Hota, I think the time is going up.
We are has there been Vinod? Has there been a test to know the penetration?
No,
sir. Andrologist could find out a test for penetration.
Sir, the gynecologist can help us by doing a postcoital.
No. That's
Vinod, we are reminded about our time now. I think what should be done in this situation? Wife was counsel and vaginal probing in presence of husband, and that is how I think he could know where to penetrate. This is the case. This is a live case. What I had treated, in fact. Now the message is lack of sexual knowledge is also a contributing factor in unconjugated marriage, mainly amongst illiterate, fastidious with strong religious background amongst rural population. Multidisciplinary approach is required along with confidence building and the use of PDE5 inhibitors, ICBAT, for sustained erections. ART is not to be considered even if there is a strong demand by the couple. Now we come to the third scenario. Couple, husband 24 years, wife 22 years, married for 5 years, presented to the obstetric gynecology specialist due to social and family pressure for treatment of infertility. On evaluation, it was found to be an unconjugated marriage. Now, what are the relevant? Already we have discussed the relevant and specific sexual history we have to take. The husband says he was having good erection and was enjoying the foreplay. The moment he makes an attempt for penetration, wife screams with pain and he loses his erection. How to evaluate the female? Pastor Mahapatra.
I will say that yes, this is also a very common problem. But I will tell first that you are married against law. At 17 years, you are married because it's 22 years and 5 years marriage and all that. So in the young age group, that's also a common problem with the defective conjugation where dyspareunia could be a major thing for that. And I will first evaluate and exclude any organic pathology for the genital tract for that, and then go ahead with the other things for that.
Over the years, with the unsuccessful attempt and not to give pain to his wife, he is no more having a good and proper erection and has abstained from sex, but maintaining a normal family life. They have presented for having a child. What should be your approach now? Professor Shivam.
Yeah. I think if the person is not having a good erection, then definitely we need to go ahead and evaluate the person, a male person, and treat his erectile dysfunction also. And then the gynecologist also should examine the female about ruling out vaginismus and other pathologies which may not result in penetration into the vagina. So I think both the partners, the couple should be treated simultaneously, and they should be properly counseled, and then we should go ahead.
Now, I think the very interesting part is that he has got both the components. Just not to give pain, he has developed secondary ED also. Yes, develop secondary ED. Now, Professor Mahapatra, how often you encounter such couples?
I think it's not very uncommon. I find quite a good number of cases presenting with this, and simple counseling, and some of the cases where I find that just vagina admits one finger only. I do when I advise for examination and anesthesia and introital dilatation, and advise for a subsequent vaginal boogie for 3 months, and along with infertility investigation, doing a hysteroscopy, laparoscopy, and all that. And then many of the cases are very satisfied and blessed with the babies after that also.
They say that they are only interested to have a child and not very concerned about their sexual life, because the husband is very sympathetic towards his wife, not to induce any pain. What should be your approach now?
No, see, I must salute the husband that he's a very sympathetic husband for the wife, but it doesn't serve any purpose for that. And because it's a secondary thing resulting out of the dyspareunia, we must try to correct the dyspareunia. If the dyspareunia is corrected by eliminating the organic cause and solution out of it, also I think that problem will be solved.
So I think here, another thing that I commonly do is, suggest a self-dilatation of the vagina by the female partner, because these dilators are now easily available over e-commerce portals. An unofficial way would be to use an artificial male penis also to allay the anxiety of that female. So that is also something that we can suggest, but of course not on paper. You can ask them to buy a dildo, and the female can condition herself to allow the penis to enter.
I think boogie is available. I think plenty available, and boogie is successful is there. But one should have a confidence. If you do an EUA and find out and eliminate the pathological conditions, I think majority of these can be solved for that.
I think this is again a couple's problem. Both has to be addressed. The male ED that he has developed, and the gynecologist has to take care about the painful encounter the lady apprehending. Now, because of the time constraint, we are skipping this because we have discussed all these things. And message should be painful sexual encounter like perceptual pain, dyspareunia, vaginismus, a common cause of UCM. Major because of female factor, which includes introital narrowing, congenital constriction ring, vulvovaginitis, and vaginal atresia. Examination under anesthesia and bougie dilation with follow-up counseling helps in consummation. Now we have the very short case, the last one. Young
Dr. I think you're exceeding the time.
Only 3-4 minutes, sir. If you permit, this is a very interesting case. A young bureaucrat of 28 years presented with infertility. His wife is 25 years old and a bank employee. On queries, he failed to have penovaginal intercourse as he was not having erection, but was having a good erection in oral intercourse. He and his wife are happy with this sexual life for last 4 years. He is presenting for his parental pressure to have a child. Again, most of the time they present to the obstetric gynecologist for their having a child. How common is this situation encountered in our practice? Again, Professor Sivam, quickly, let's make it within 5 minutes.
Right. I think this is quite not very uncommon also. So many a times what happens, the male partner is used to masturbatory erections. So they may not have a kind of penetrative sex, and they may not have erections while during sex. So they get used to this kind of oral sex. And many times the wife has also a phobia, maybe of a fear of pain while introducing the penis. So both of the partners get used to this kind of alternative arrangement for sex rather than having a penovaginal intercourse.
Yeah, Vinod, what should be the approach in this case?
Sir, when I approach an unconsummated marriage couple, the primary aim is to have more intimacy and have their pleasures. Whatever way they do it is up to them to decide. There are different combinations we have seen. Oral sex is sufficient for the male, and for some females, the opposite is comfortable.
So the problem is not that they have come to resume a penovaginal sex. They have come to you for a child.
Yeah, that is what, sir. That is what, sir. So if they are comfortable with the sex they are having and they are happy about it, then we can go for a ART for not ART. Actually, an IUI should be
Now, Raman, quickly your viewpoint on this, quickly.
So I think basically, as Dr. Vinod said, this is just the way of thinking. Just make sure that, this is not happening because they have some sort of a back history of abuse or some sort of a aversion, or it's not a psychiatric problem. So from that perspective, if they are all healthy, then I think we can allow this also to happen. But at the same time, counsel them about the other areas that they can explore and they should explore being a couple.
If they are happily enjoying their sexual life, can we offer them ART if they are demanding? Pramod?
Yes, sir, definitely. Why not? We can definitely offer the ART, sir. Because
What
their
about-
aim is to have a child. So,
Yeah.
yes.
What about our gynecologist opinion?
Well, certainly I will have three options. First is that they are happy about that Pinot-oral, but still I will try that Pinot-vaginal is more pleasurable than Pinot-oral. That I will advise for that, number one. Number two, if they are happy about this oral, I think I will tell that don't go to andrologist, go to an oral surgeon. Leave the andrologist, forget about the andrologist. Third is that I will go for an ART for procedure for that to have a baby.
Is there any ethical issue in this thing? Do you find any ethical issue? Quickly, viewpoint from anybody. Quickly, another 1 minute and we are finishing.
And it's a personal issue. It's not an ethical issue. I don't think it's an ethical issue. It's a part of
No,
that.
from the
There is
doctor's point of view.
sorry,
From doctor's
we are
point of view.
even we are having LGBT being legalized.
No, that is a different aspect altogether. But this is a heterosexual marriage, and they want to have a ART. That's the reason we are talking about.
So I don't think that
it has
comes
to-
under the ethical views and all that.
Okay.
If the partners change, or if the partners change, then there could be a ethical issue. Otherwise, it does not.
Okay. I think thank you all. I think the final message: adapting to alternative sexual practice is not uncommon. A detailed psychosexual history can give the lead to this behavior. Needs multidisciplinary, multimodal approach for successful consummation. As far as practical, we should try to. And here is the only situation in refractory cases, AIH may be an option. Thank you all. Thank you, USI central body, to our president, to our honorary secretary, to the chairman of the ISU. I think with this whole program, the USI Andrology cell express its thanks for giving the time and opportunity. Thank you all.
And special thanks to the USI for inviting me as a gynecologist as an odd man out and participated in this academic endeavor. I think I have enjoyed all of this. Special thanks to Datteswar Hota, who has called me for that because of our anterior relationship. I always say urologist and gynecologist have an anterior posterior relationship and all that, and we'll maintain that forever and all that.
Thank you, sir, for giving this privilege to hear you in our forum. Thanks a lot, sir.
Thank you.
Sir, Dr. Mahapatra doesn't look like a gynecologist. He's a super andrologist.
No.
Thank you, Dr. Hota and Andrology Cell for this wonderful webinar. I must thank all the international faculty on behalf of the Urological Society of India and the national faculty for a wonderful webinar. The lectures were excellent and I thoroughly enjoyed it. Now I would hand over to Dr. Arun Chawla to make a brief comment and then call Dr. Rajiv Sood for his closing remarks. Over to you, Dr. Arun. Arun Chawla, are you there?
Yeah, he's there. Very good.
Yeah. Can you hear me?
Yes, sir.
Yeah. So very interesting webinar, and I think just a very quick comments. Dr. Hanumantra talked in the session 1 about the various penile cutaneous region was very informative. So many learning points. Dr. Stephanie discussed very nicely about the psychological aspect of sex therapy and the way to handle it by talking to both the partners and spending more time and counseling. And as always, Dr. Kotari was his very best while talking about the myths and misconceptions in the sexual medicine. A great talk from him. Dr. Ralph made a very crisp and cogent presentation about the update on the Peyronie disease, both talking about the management of acute phase as well as the stable phase. A very nice presentation from him. Dr. Sijos made a very interesting and very informative presentation on arcalgia, a subject which is not routinely discussed in the various forum. It was a beautiful and a very nice presentation from him. The panel discussion followed in the second session on the unconsummated marriages with involvement of a faculty was very, very interesting. So many viewpoints summarizing the multimodality treatment, right from the history to the use of examination, the use of medicines, and everything was discussed very nicely by the faculty. And overall, a very, very nice webinar and a very well spent Saturday academic evening. Thanks to all the international faculty, Stephanie, Professor Ralph, Sijo, and the national faculty for this webinar, for your contributions. Thanks to Navneet and the central office for the logistics support. Thanks to all the viewers for staying with us live for today's program. And with this, I hand over to Dr. Keshav back.
Thank you, Dr. Arun. Now I would invite Dr. Rajiv Sood, Chairman ISU, for his closing remarks.
Thank you. This is thank you, Keshav. This and everybody, Dr. Hota, Shivam, Dr. Prakash Kotari, Arun Chawla, Dr. Mahapatra, Dr. Vinod, so, Pramod, everybody who has participated has given something which was lacking in the routine webinars. It is one of the, I was reading Dr. Panda writing that it is one of the unusual but very, very important CME. And the way the attendance has gone up in this webinar, that is self-telling story. We started with very humble beginning in USI a decade or 15 years back, and now gradually we have full-fledged subspecialty section, and it is doing wonders. We are hoping that this specialty, andrology, which is very important, and also now Men's Health Month, which is going on, it is a major part of that. ED is the barometer of men's health. And erectile dysfunction, when we talk about whether it is because of any cause or maybe the unconsummate marriage. I remember that one of the sitting judge in the had come. He was around 50 years, and they had around for 15-20 years unconsummate marriage. They had no child, and now after they attended the clinic, they are blessed. There are, I'll not go into the details, but they have baby boy now. So bad, and it was natural. There are so many misconceptions. Dr. Prakash Kotari, after a long time, I remember hearing him 20 years back in USI conferences, where he told that what is the relation of a professional and client. If you treat your patient as a perfect client, you have to do the professional service, and also you have to satisfy him. If urology society, if the qualified doctors are taking up these issues, then that is the perfect way. But what is happening, rightly was said by Dr. Kotari, that some of the qualified doctors are behaving like quacks. And that should not happen. And if doctors have to behave like doctors for this important subspecialty, they should have more and more literature, more and more CMEs, and more interactive sessions. And that is what has happened today. National and international faculty has perfectly touched each and every aspect. I'm really thankful to Dr. Dateshwar Hota, especially because he organized the whole thing such a beautiful way that even when the time has crossed its limit, people were not disappointed, but they are still writing in the chat box that they thoroughly enjoyed today's CME. Let us have more and more interactions under this subspecialty. This subspecialty has done a wonderful season last year, and it is continuing, and we will do whatever is expected by USI from us. And this is the message from Indian School of Urology, that all the subspecialties will grow. And what was the vision in 2017 for 5 years that we should be the global leader amongst all the subspecialties of urology, and that is what is happening. We are developing our archives, we are developing our treasure. We are the rich now, academically rich, resource wise rich, and very soon all the edited videos and lectures and other material which has been prepared, that will be very well presented for the viewing for our young consultants and residents also. Dr. Tawar is also recently chipping in very effectively. He is doing a very good job, and our secretary and president always supportive. Whole the USI Council is very supportive, and that is the story of success of Indian School of Urology and especially Andrology subspecialty. Congratulations to each and everybody for today's success, and we will continue these endeavors in future also. Stay tuned. Thank you.
Thank you, Chairman ISU, sir, for the kind words. Thanks so much.
Thank you. Good night to all of you, and good day to the international speakers.
Good night to
Thank
all.
you, sir. Thank you. Thank you, everyone. Thank you.
Thank you. Thank you.
Bye.
Bye-bye.